What's up, guys? It's Dinith here, and welcome to the Daily Dose of OSPE's 8. And before going into the OSPE questions, I want to wish you all a very happy Vesak full moon Pole day. So, going into the question, we have a 50-year-old patient who was on low-dose aspirin, clopidogrel, and atorvastatin after a non-ST segment elevated myocardial infarction presented to the surgical ward with mild cellulitis. The patient was prescribed with oral erythromycin as the treatment option. After 3 days of treatment, the patient was complained about fever, myalgia, and the dark urine discoloration as given in the picture. So, before diving into the pharmacological basis of the question, let's discuss about some pathology and recall what an ST segment elevated myocardial infarction is. So I'll quickly recall the pathology. So what generally happens here is, in a non-STEMI, it occurs in a partially occlusive thrombus. In a partially occlusive thrombus, in addition to non-STEMIs, even unstable anginas can occur. So you can see the involvement of the myocardium is generally in the subendocardial areas. But in a STEMI, there's a pre-existing plaque, and the thrombus happens, and the thrombus occludes the myocardium completely or more than 90%. So if it is more than 90% or completely occluded thrombus in the blood vessel in the heart, in such cases, it gives a ST elevated myocardial infarction with the entire thickness involvement of the myocardium. So it's called as a transmural infarction. So in those cases, we can see an ST segment elevation from the J point. And in non-STEMIs, there's ST depression and T inversions. So that is the common pathological basis of the non-STEMIs. So something about these questions is like the drugs they have given is aspirin, clopid, and atorvastatin. So one thing that the pharmacology department is quite famous on doing is bringing stuff from other cats and asking in this cat. This was also evident in the cat 3. So let's go like, why did they give aspirin, clopid, and atorvastatin? So this is why it's given. In generally, when managing a non-STEMI or a STEMI, there's a flow chart or a general pathway that they go. Firstly, we'll discuss the pharmacology thing. So generally, we give antiplatelet therapy and anticoagulant therapy. In antiplatelet therapy, we have seen like they give a dual antiplatelet therapy. So since we are doing the medicine appointments, and since like all of us have done one medicine appointment, in the BHTs, we can see 2 antiplatelet drugs and an anticoagulant like enoxaparin, and a lipid lowering agent like a statin is given. So in the dual antiplatelet therapy, so here aspirin and clopidogrel is given, and as a secondary prevention method, the lipid lowering agent given here is statin. So we can see here dual antiplatelet therapy is recommended for patients with acute coronary syndromes, and high intensity statin therapy is recommended for all patients with acute coronary syndromes. So what has happened is, so the patient has taken these drugs, then was it 3 days later, then he developed a mild cellulitis, and after the cellulitis was treated with erythromycin, and later he developed fever, myalgia, and dark urine discoloration. So the patient presented with dark colored discoloration of urine. So it can be myoglobinuria. It can be even hematuria, because hematuria also can take this dark color. So in such cases, we go to the history of the patient. So if it's hematuria, then generally the patient will present with urinary symptoms like dysuria, flank pain, and whatnot. Like the classical urinary symptoms would present in this patient. But in this patient, it was myalgia. So this myalgia, it indicates something wrong with the muscles. So in such cases, we can do a creatine kinase. So in the creatine kinase, if the creatine kinase levels are more than 5 times elevated than the normal, so it is highly suggestive of rhabdomyolysis. So what is the reason for the discoloration of his urine? It is due to myoglobinuria. So what is a clinical diagnosis regarding these new clinical symptoms of the patient? So the patient had this condition called cellulitis. So what is cellulitis? Cellulitis is a condition like as you have seen cellulitis patients in the surgical appointment. So in the features of cellulitis, we can see this redness, swelling, heat and pain. The typical features of inflammation can be seen in the leg. In addition to that, it is mostly caused by strep pyogenes, which is group A streptococci. And when identifying between cellulitis and erysipelas, so in erysipelas we can see distinct margins, but in cellulitis you can see the margins are not very distinct. They kind of fade away and they blend in with the normal skin. And also another feature is like erysipelas, they are present in face and other areas. Like cellulitis in general, we can see it in the limbs and hands and those areas, generally in the limbs, but that's not very common. But the most common feature of distinguishing cellulitis and erysipelas is the like the marginal demarcation and all that. So diving into the question, so they are asking in the second part of the question, what is our clinical diagnosis regarding these new clinical symptoms of the patient? So the new clinical symptoms are fever, myalgia and dark colored urine, which is suggestive of rhabdomyolysis. So it can be, so what is the case? So like most of y'all might know what it is. So what can it be? It is statin induced myopathy. So in statin induced myopathy, so why statin induced myopathy? Because the patient was prescribed on lipid lowering agent called atorvastatin, so which is a statin drug. So this statin drug has caused this myopathy in this patient. So in this patient, we know atorvastatin is metabolized by the CYP450 enzymes of the liver. So erythromycin is a CYP enzyme inhibitor. So what it essentially does is it prevents it inhibits the CYP enzymes. So as a result, the metabolism of atorvastatin is slowed down. So the concentration of atorvastatin increases. In such cases, it can lead to atorvastatin accumulation, and the high concentration and the accumulation of atorvastatin can give rise to statin-induced myopathy. So, general adverse effects of statin, gastrointestinal symptoms, hyperglycemia, altered liver enzymes and all that. But this muscle effects like myopathy and rhabdomyolysis, those are serious adverse effects which are quite rare. In such cases, we advise the patient to meet the doctor as soon as you get a muscle pain, or like if the creatine kinase is elevated more than 5 times the upper limit of normal, we advise the patient to stop taking statins under the advice of the doctors. Since we are doing the IPD module, I thought of recalling some pharmacology through this question. So we all know that erythromycin is a macrolide. So other macrolides, we have erythromycin, clarithromycin and azithromycin. Those are the commonly discussed macrolides. So out of this, azithromycin, we can see many advantages of azithromycin. For example, it has minimal hepatic metabolism, so they don't have any active metabolites. As a result, they don't undergo many interactions, so they have fewer interactions. Because of that, it is the preferred drug out of the given macrolides. It is the preferred drug in polypharmacy. And because they have good tissue penetration, so just imagine they can enter cells and they can concentrate well in these cells. And as a result, their half-life is quite longer. So as you can see, the half-life of erythromycin and clarithromycin is in the range of 1 hour, like 1.5 hours, about 8-7 hours in clarithro. So, but in azithromycin, there's an extended half-life. So giving once daily dosing is enough. So again, it supports the compliance of the patient. But when it comes to erythromycin and clarithromycin, so both of them, and they are strong CYP enzyme inhibitors. As a result, they give rise to many interactions. And also their half-life is also short. So erythromycin should be prescribed 6 hours, which means 4 times a day. So here you can see the interactions of macrolides with other drugs like statins, warfarins, calcium channel blockers, digoxin, antiarrhythmetics and benzodiazepines. So like because of that, we try to avoid these combinational treatments. Or in such cases, we assert alternative treatments. For example, with antiarrhythmetics, using macrolides is contraindicated because, for example, like class 1A and 3A antiarrhythmetics, well, 1A arithmetics which includes quinidine and 3A antiarrhythmetics which includes sotalol and amiodarone, they are contraindicated to be used with macrolides. And also, it is contraindicated to use macrolides with patients who have prolonged QT intervals. and moreover it is contraindicated in pregnancy. It's a DA classification, it's a class C contraindication for pregnancy. So the other adverse effects that are greater with erythromycin are GI related side effects, so like nausea, vomiting, diarrhea and abdominal pain. And also we know that macrolides are motilin agonists. As a result, they increase the gastrointestinal movements, giving rise to these gastrointestinal symptoms. Moreover, they give rise to metallic taste in mouth, QT prolongation, hepatotoxicity in pregnant women, and sensory neural hearing loss. So these adverse effects are more common with erythromycin, and other adverse effects includes Stevens-Johnson syndrome, toxic epidermal necrolysis, and pyloric stenosis in newborn. So what are the general indications of macrolides? Macrolides are indicated for both typical and atypical pneumonia. So atypical pneumonia includes even mycoplasma pneumonia. So in typical pneumonias, we treat pneumonia according to this curve 65 score. In curve 65, C is for confusion, U is for blood urea levels, R is for respiratory rate, and B is for systolic blood pressure, and 65 is for age. And generally for low levels of curve like 0, 1, we give amoxicillin, and higher grading penicillins like coamoxiclav is combined with clarithromycin in a case of moderate curve, and in severe curve we combine ceftriaxone with clarithromycin in the cases of severe curve. And other indications of macrolides, so macrolide is given as a maintenance therapy in conditions such as bronchiectasis and COPD, and prescribing macrolides help in reducing the exacerbations of COPD. In addition to that, it is given in pharyngitis, tonsillitis, sinusitis, and also triple therapy for the H. pylori infection, clarithromycin and amoxicillin and omeprazole, which is a proton pump inhibitor. So, and also the macrolides are used for sexually transmitted infections, for example, particularly azithromycin, which is used in Klebsiella granulomatis, Chlamydia trachomatis, Neisseria gonorrhoeae, Haemophilus duceri, and in these cases it's azithromycin which is used. And those are the common indications of macrolides. Yes, so you recalled about macrolides through this question. So we have one more part to discuss. It's what is the most effective preventive measure to prevent this presentation. So first thing is, like in these cases, we should be aware about the drugs the patient is on before prescribing erythromycin. So now the thing has happened already. So what we can do is we have to stop giving erythromycin to this patient and give an alternative drug. So we know in treating cellulitis, in the mild cellulitis condition, the first line drugs are the penicillins, which are amoxicillin or cephalexin or flucloxacillin. So generally the patient who is allergic to beta lactams, in those patients it's erythromycin that is given. So we can go into an alternative drug. So yes, that is about the question, and I hope you all understood the discussion, and thank you for listening.